Good? Better than Friday? Yeah? No? Quiet? All right. Sound good. Guys, we're obviously going to go over hospital indemnities today and how I pair them with Medicare Advantage. Then you're going to get my take. Then Norman's going to come up here and give you his take as well to give you a couple different options on how to present them, how to get more clients to want the hospital indemnity plans. Before I do that, I did have a couple questions on Mutual Omaha list. Some of the veterans probably have done it before. I don't know if any of the new ones, but Mutual Omaha is paired with USA Data. They'll give you lists, you can customize them, you can do T65s, you can do folks that just had a baby. There's a whole list of things that you can customize, and it's a little bit discounted. So typically I spend about $50 per 1,000. Okay, you can pick your thing. So if everyone just wants to take one of these, pass it along, that gives you all the information on it. That's the website at the bottom that you can go to. Typically, you fill it in, you pay for it, in about an hour, 2 hours, you'll have the list sent to your email. So it's usually pretty quickly something that you can do. Another little resource that you guys can use other than the calling material that Cornerstone has for you. With that being said, hospital indemnities with Medicare Advantage, guys, I've started talking about this in every house because I experienced it firsthand. I lost my stepfather in 2023, and he was on a Medicare Advantage plan, and I had it paired with a hospital indemnity. And after he had passed, and I had my mom go through all of his bills over the last year while he was sick. And he was in and out of the hospital a lot, ambulance transports, all different kinds of stuff was going on with him. And it came down to the total bill from MUSC was around $2 million in what was charged. Obviously his Aetna kicked in that he had, which we had him with a low max out of pocket, and paired with his GTL, they ended up spending out of pocket $1,500 to $1,700 out of a $2 million bill. And that was just portions that the hospital indemnity didn't cover. But that's really, really, really impactful. I feel like most of our clients at some point could experience something that's going to lead to multiple high-level copays. Hospital, ambulance, outpatient surgery, physical therapy. Physical therapy is a huge one, guys, because typically when they're getting physical therapy, they're going at least twice a week. And it's considered a specialist copay. That can add up pretty quickly. My two favorite companies that I bounce from is GTL and UNL. Obviously, they're owned by the same company. I prefer GTL over UNL. The reason why I prefer GTL over UNL is GTL adds a couple extra things in there that UNL does not. One of those being is an emergency room. If they go to the emergency room because of an accident or injury, it's going to reimburse them $150. UNL doesn't do that. That's not a rider that you have to put on there with GTL. It's automatically included. GTL will also allow you to add a rider for physical therapy. It's usually $50 for 30 days. Typically, I see that premium coming out about $6.50, something right around that mark. So what I did is I broke it down a little bit, guys. This obviously is not one of our current Medicare Advantage plans on the side. It's one that I've used in onboarding training for a while. But I used the numbers from this Medicare Advantage plan with Humana on the left side, paired it up with a GTL on the right side. I believe it was a 65-year-old, I believe. So I added the hospital confinement rider for $350. Theirs is $298. I usually go a little bit above. I don't want to have to redo this year after year and do an increase in benefits. I try to go a little bit above where they're at now so that hopefully down the road, if we switch them to another Medicare Advantage plan, they're still covered underneath of this. Ambulance, $300. That just matches the ambulance on this Humana plan. Outpatient therapy, once again, at $50 for 30 days. Under this one, they would have been responsible for $5. Okay. Skilled nursing, back when skilled nursing was 193 or 196, days 21 through 100, I went ahead and put this one at 200, a little bit above it. Outpatient surgical rider, I always go at 500. That should cover any carrier we have now. Right? For all that benefit, guys, it came out to $55.91. I feel that's pretty cheap to be able to cover all the higher co-pays inside these Medicare Advantage plans. So I did a little case here with it, guys, and I'm going to go back here because I can't see. Looking up like that. So Mr. Jones fell at home, was transferred to the hospital to check his hip that they believed was broke. Once he arrived at the hospital, they confirmed his hip was broke and it will require surgery. I don't know if you guys know this or not, but a lot of my clients, or a good portion of them, are on blood thinners for this reason or that reason. Typically, you have to come off blood thinners for a certain amount of days to be able to have some type of surgery. That was the scenario here. We're saying Mr. Jones is on blood thinners. They needed to wait 3 days before they could do his hip surgery. On day 4, they went ahead and did his hip surgery. Surgery went well. They wanted to keep him for a day or two just to make sure everything was going all right with him and then start him back up on his blood thinners. Mr. Jones, after 6 days in the hospital, is now being transferred to a skilled nursing facility for rehab for his hip. He's making steady progress, so Medicare's covering days 1 through 20, but they believe he's going to be there for a total of 30 to 45 days. At day 40, they went ahead and sent him home to continue therapy on an outpatient rehab basis for an additional 30 days. Is everybody following along with me here? These are his co-pays that he just experienced with this fall at home, okay? The ambulance was going to cost him $300. His hospital stays is going to be $298. The ER visit was $110. Skilled nursing after 20 days was $196. And his physical therapy rehab is going to be a $5 copay per visit. These are the bills he received from being in the hospital. It equated to $1,490 for the hospital stay. Skilled nursing cost him about $3,920. Outpatient rehab came to $150 for a total of $5,970. How many of your clients, if they fell at home and experienced this, would be able to go ahead and pay the $5,970? I have very few clients that could do that, guys. I assume you guys do too with the folks that you're going to see. Guys, when I'm presenting this to clients, I'm using these large numbers like this, right? His GTL policy, once he got home, I went out, I helped him file all the claims for this. His GTL policy reimbursed him $300 for the ambulance, $1,750 for the hospital stay. The ER, they reimbursed him $150, $4,000 for his skilled nursing, and $1,500 for his rehab, for a total of $7,700. So the $7,700 he received from GTL, he was able to pay his $5,970 hospital bill without coming out of pocket anything, and he was left with $1,730 after paying his bills from his fall. Guys, if you had a client that this happened to, and they were able to get a check for $7,700 to pay a just shy of $6,000 hospital bill, how many referrals do you think that you would possibly get from this client? Nobody wants to go to the hospital. No, I hope none of my clients experience this, but getting a $1,700 check just to put into the bank to make a little buffer, it's pretty nice for seniors, right? Probably more than what their Social Security is a month. Mr. Jones pays $662.52 a year for this GTL policy. In 9 years paying premiums, he would have paid a total of $5,962. After his one fall, we obviously know he was reimbursed the $7,700. If he chose to save the $662, because it would have taken him 9 years to pay the hospital bill. I think it's easier to come up with $55.21 than it is to come up with the $5,962. I think every client would agree to that. I know the phones are hard, guys, and I know that we just came out of AEP and we just came out of OEP, and the clients are tired of people calling asking them, let me come do a Medicare review. Correct? Everybody agree on that? Okay, so what if we change that spiel a little bit when we're on the phone with them? I'm not here to mess with your Medicare Advantage plan. I have one question for you. Did your agent pair that secondary policy to cover your larger copays, such as hospital, ambulance, outpatient surgery? Most are going to say no, because not everybody does that, right? Or I don't know. Great. I specialize in helping Medicare Advantage plans beneficiaries minimize the out-of-pocket costs associated with MAPD plans. Will morning or afternoon work for you for me to come show you how this program works? Pretty easy phone call. A little bit different. Don't ask them if they want you to come out. Tell them you're going to be out there. Does morning or afternoon work? Try that on the phones, guys, and see if that may help or change that phone call a little bit. Not that saying that you can't go in there and you can't help them maybe change a Medicare Advantage plan that would be better fit for them. But this is probably going to be a heck of a lot easier phone call than saying, hey, I'm coming out to do a Medicare review. Does morning or afternoon work better for you? Does anybody have any questions? It's kind of straight to the point. Does everyone feel that hospital indemnity should be paired with every Medicare Advantage plan as long as it's not a Medicaid plan? Mm-hmm. Okay. So if John did the numbers here, guys, on average, let's say it's a $700 a month premium, right? Convention credits are going to give you $700
annually.
Annually, that's what I meant. Annually. $1,750 towards convention credits. If you do one a week, that's $91,000 in convention credits. If you pair that with a Medicare Advantage plan, it's $195,000 in convention credits. I think everybody wants to go to Hawaii in here. I'm pretty sure. It's a pretty easy way to get there, or a good start to get there. The average commission is about $175 on a hospital indemnity plan. Average Medicare Advantage is $150. That's $325 commission you just made yourself by covering all these gaps and protecting your client in the event that something like that should happen. It's a win-win situation, right? That's $16,900 in commission. Pretty easy. Guys, you've got to draw this out for them. Sitting here and talking to them, hey, it's going to cover this, it's going to cover this, it's going to cover this. Write it out. I'll do it on the back of the fact finder. Hey, this is your total bill for hospital. This is the ambulance. This is this. And I pare it right down. Calculate worst case scenario if all that stuff happened to them, what's the total versus the total that they're going to pay monthly for the GTL policy or UNL.
And remind them, it's not too terribly long ago, they were all paying premiums on these plans.
Absolutely. Medicare Advantage 5 years ago was not free. Does everybody remember the yellow sheets? I know that we've pushed the yellow sheets for a few years. Guys, this is great to fill out, leave with the client. It does exactly what I just did up here, just leaves it with them. I'm going to pass some of these around. There's a ton of them up here, guys. Grab them, use them. If you're going to see somebody, Medicare beneficiary, have them in your folder. Hey, this is why we're doing this, and put it there. Next AEP comes around, and they get a phone call to talk about their Medicare Advantage plan. Do you think they're gonna switch with somebody else, or are they gonna call you to make sure that that Medicare Advantage plan works with the GTL or the UNL? They're probably gonna call you. Everybody agree?
Yep.
Alright guys, that's my take on it. I firmly believe in these a lot. GTL is, no questions asked, up to 72 now. That's huge, right?
Say that again?
GTL, I believe, is guaranteed issue from 64 and a half to 72 now. 70. 70, sorry, 70. They do, GTL does have a guaranteed issue hospital indemnity plan as well. For all ages, it is expensive. You cannot add all the riders onto it that you can with this one, but some coverage is better than no coverage. If you have a client that is, let's say 75, and they don't qualify, they cannot answer the health questions. I got one that has COPD, can't answer the health questions. You could go UNL home health care and add a hospital indemnity rider on, and they don't ask any health questions. So you cover the home health care bit, and they also got the a little bit of the hospital indemnity. It's not going to be as big as the GTL or as many riders, but once again, something's better than nothing. All right, that's all I have. Norman's going to come up and give you guys his take on hospital indemnity. Norman sells a ton of Medicare Advantage, and I'm sure he has a great way of just going about it.
So everybody pretty much got the gist of what he was saying. I use GTL, I use UNL, I also use Medico as well. I find that Medico, when I go, I've actually went back and looked back in the history of my clients and found some GTLs that I was able to replace with Medico and save them a few dollars. So I'm starting to think that Medico is a cheaper alternative. What I did here, when you start looking at, when I go into a house and I do a Medicare presentation, let's just say I'm using United Healthcare, I'm using Humana, I will go through the summary of benefits. So the summary of benefits is gonna basically break down what the plan covers and then what your copay is gonna be. So then I'd have that on one side, and then the other side, I would have the Medico hospital indemnity and all of the riders that are gonna close those gaps or pay for those copays, just like we saw here previously. What I did is I actually printed those out. See those out. And then the printout that you're getting right now, what that does is actually gives a detailed description of what that rider actually does. So you have your ambulance, your out-of-pocket therapy, skilled nursing facility, what they actually mean by that, and then how much they're gonna give you per rider. So I might say, okay, ambulance or hospital indemnity, what exactly does that mean? So what it does is I'll read through it with the client that says, okay, here's the rider benefit, and this is exactly what it means for that rider benefit. These right here just is a brochure for the Medico hospital indemnity. And if you call Medico, they'll send you as many as you want. This is the brochure. So what I'll do is I'll start with the brochure, kind of explain to them. A lot of folks are coming out of the workforce like your T65. If you say something like Aflac, then they kind of understand what the Medico policy does, or what the UNL does, or what the GTL does. So once I say that, then I kind of go into an explanation how, usually, first I was just going with, okay, so let's close the gap for the hospital, but those other riders are important as well. So if you go down the summary of benefits, and then you say, okay, and then I also remind them too, hey, this Medicare Advantage plan that I'm giving you, the monthly premium is $0. So why don't we take $40 or $50 and close all those gaps? So between your Medicare Advantage and your hospital indemnity, you're basically $0 out of pocket because you're gonna get reimbursed for that. So that's how I kind of present it. I'll go through the summary of benefits, go through the riders, and then I'll match them up. Okay, so Yeah, $350 a day for the first 5 days. Let's look at that. Let's look at the hospital copay. Let's close that gap. Let's look at the ambulance. Let's look at this, look at that. And then as I'm doing it, I'll have that quoting tool up. Medico has, under the Wellbe umbrella, they have the quoting tool where you can go to hospital indemnity. And as I'm doing that, then up on the right-hand side, they're seeing, okay, $32, $49. And then as I'm adding and deducting riders, we kind of get to a sweet spot of where they think that that could fit in their budget. We closed all that gaps, they know they can afford that, and we're linking the two together. So as Matt said, come AEP next year, more than likely, they're gonna wanna deal with you because you already gave them the impression that those two things are linked together. That's why you're gonna do that summary of benefits, and you're gonna go through the riders for either your GTL or your Medico. That's what I do. Any questions?
Yeah, and that's a good point, 'cause the key thing is giving them maybe two options, the sweet spot, because if they are tight on income, and it has been a couple of years since, because it used to be very simple, or no-brainers, we used to say, that if they paid $28 a month to a plan, you put them in a $28 hospital indemnity up there, increase their benefits, but the money evened themselves out.
Right.
Now, they've gotten used to these zero premium plans, and so they're just not thinking about it, but you do need to take the time to maybe give them more than one option. Don't try to put them in, the all bells and whistles policy, and then they regret it 6 months in. Fit them in something that they can afford.
Yeah, so they kind of watch that ticker while I'm adding the riders on, and then it gets to a point where they say, okay, I can fit that in my budget. Also, too, if you have you're doing a T65, naturally you're gonna offer both sides of the fence. You're gonna offer a supplement, and you're also gonna offer a Medicare Advantage plan. What if someone says, well, okay, I got the supplement, then I gotta pay for a Part D, I don't get the dental, I don't get the vision. Well, if you were able to afford $100 a month for a supplement at a T65, let's take that $100 a month and put it all into the hospital indemnity plan, right? You're still paying $100 a month, but then you're getting everything. So you're getting more in your basket than if you were doing a supplement. So that's how you can frame that too. So when you're going into a T65 house, offer both sides and let them pay.
With the premiums for the GTL and Medico, does that go up with age, or is it set in stone once they?
It's set.
Okay.
Yeah.
As far as the benefit package, the GTR, UNL pays a certain amount of days per year, right? That doesn't generate. The others is just a benefit period, am I right in that? So, my understanding on UNL is if you do 5 days, that's 5 days that you're reimbursed for the year.
Oh, and I think there's one point where that'll actually replenish after a certain amount of time.
Restoration of benefits.
Yeah, what is it?
60 or 90 days, I wanna say.
So it does replenish.
3
On
months.
the hospital indemnity,
Yeah, for GTL.
For GTL, it does.
for GTL, but not UNL, right?
You and L have Delta.
Now you have to pick the amount of days,
And that's the calendar days.
like your 5 days or
That's how
9
many in a
days
calendar year.
Right.
for the calendar year for you and us.
I believe UNL does have a cap on how many times they'll pay out for the same benefit.
Also too, for a lot of the folks that have been here a while, like I said, I go back into previous business that I wrote over the years, and I have went back and looked at some GTLs, and been able to save them money on a Medico, and I was able to get back in the house. So you can get back in the house, save them 10 or 12 bucks, or I can say, what you were paying for that GTL, I can do a hospital indemnity on a Medico and add you 1 or 2 riders. So now you're getting more bang for your buck, and you're not paying anymore.
Well, now, does Medco offer basically the same kind of riders that the GTL does?
Yeah, pretty much. As a matter of fact, that sheet that I gave you, all the riders that are there, right under it, it gives you a paragraph of what the definition is of that rider.
Okay.
That's it.
Guys, I think me and Norman both hit the same point here, is you've got to break it down for them. Like, you've got to show them hospital is gonna cost you this, ambulance is gonna bring up those higher copays that maybe you might shy away from when you're selling a Medicare Advantage plan. Don't shy away from it, bring it up and tell them, don't worry, I have something that's gonna take care of that.
Yeah, And that's what I do. When I'm going through the summary of benefits, I'll show them that, and I'll say, don't worry about that, when we finish, I'll go back and show you how we can close those gaps.
Yeah, yeah. So once I'm usually done with a Medicare Advantage plan and talking to them and I've got them enrolled in it, then they're asking me, what about that thing that you said would cover all of this?
Right.
You just have to talk about it, guys. If you talk about it, you're gonna get people that are interested in it. So, new folks, make sure before you leave, that you